This is Dr. Jonathan Rubenstein. I want to talk about the updated CPT codes for 2026 that's starting January 1st that are of interest to urology and urologists. So it's a busy year for new CPT codes. There are a whole number of new Category 1 CPT codes and Category 3 CPT codes. The Category 3 are our emerging technology codes, or Category 1 are our live codes for established technologies. The Category 1 updates include a whole new set of prostate biopsy codes, which includes a total of 9 new CPT codes, and basically the entire section of prostate biopsy services is revised, and so it's really important to understand those new codes. There are 2 new codes for laparoscopic radical prostatectomy, which will include different levels of lymph node dissection that will be included. There's a new code for irreversible electroporation of the prostate, and that's for prostate cancer. There's a new code for cystourethropy with initial prostate commissurotomy, and then a drug delivery to help keep the prostate channel open, and that's a BPH code. And there's also a code for transurethral water jet robotic assisted resection of the prostate. Category 3 codes includes high intensity focused ultrasound for BPH, new codes to be added to the open integrated tibial nerve stimulator section, new code for low energy ureteral lithotripsy that includes cystoscopy and injection of material into the ureter, and a code for urethral autologous cell therapy. So let's get to it. So prostate biopsy codes, as like I said before, completely revamped. Before it was 3 CPT codes, now it is 11 unique CPT codes. The code that was most commonly used, which is 55700, which described prostate biopsy, any technique, has been deleted. When that code was used, ultrasound diagnostic codes and ultrasound for needle guidance codes were often reported with that code. All the new codes include imaging guidance and will not be reported separately. CPT code 55705 was slightly updated. 55706 was unchanged, and I'll describe those later. The 9 new codes have unique codes based upon different approaches, such as transrectal, transperineal, or an in-gantry approach. The type of biopsy being done, whether it's just your typical regional biopsies, along with any other ultrasound-guided areas, MRI fusion with regional sextant biopsies, MRI fusion without random regional biopsies, and in-bore codes, either CT scan or MRI. And there's a new add-on code that can be used for additional targeted lesions after the first targeted lesion in a selected number of these new codes. So, as I said before, imaging in all these codes is included and will not be reported separately. So basically, we'll be using one code per service, where in the past we may have reported diagnostic ultrasound, diagnostic MRI, or the such. Now all imaging, both diagnostic and needle guidance, is included and will not be reported separately. It's important to understand the definition of this regional sextant biopsy. This is the typical way in which prostate biopsies are performed, especially by the transrectal route, where the prostate is really divided into 6 separate areas. They call them sextants. On the left side, there's the apex, the middle, and the base. On the right side, apex, middle, and base. And typically, 2 biopsies are performed in each one of those sections, maybe more lateral and more medial in each of those sections. Now, what's important is that the general ultrasound codes, any other areas that are deemed by ultrasound to need further biopsies, let's say somebody wants to do a transitional zone biopsy, an anterior biopsy, a seminal vesicle biopsy, or any, let's say, hypoechoic areas are found during diagnostic ultrasound, and those are biopsied further, that will be included in the base code and not separately reportable. The important other definition to understand is MRI ultrasound fusion biopsy. So this is when a previously performed, read, and marked MRI is imported into a separate, unique MRI fusion ultrasound workstation. So real-time ultrasound is performed, the ultrasound and the MRI are fused together, and biopsies of the lesion or lesions that had previously been marked on the MRI are additionally biopsied on the procedure itself. So again, this must take place on an independent workstation. There are people who perform what's called a cognitive fusion biopsy, where they look at the MRI first and then use the general idea of where to perform extra biopsies. That does not meet the definition from the MRI ultrasound fusion biopsy, because that's not done on a separate machine on an independent workstation. So cognitive fusion does not count. So here's a high-level summary of prostate biopsy codes. As described before, CPT 55700 is being deleted, will not be used any longer. CPT 55705 is updated to now describe a prostate biopsy that's not imaging guided. So for example, a finger guided biopsy, we use 55705. 55706 again will be our prostate biopsy saturation biopsy. This is typically performed through a transperineal route and is a very unique procedure that the biopsy performed on 5 mm increments using a grid, basically mapping out the entire prostate gland. In its true form, this procedure is not commonly done. It's usually done for people who had previously had a biopsy that either showed a low-grade cancer or suspicious that the entire prostate needed to be mapped out. So here are the set in green of all the new CPT codes for prostate biopsy services. 55707 is our prostate biopsy using transrectal ultrasound. Again, biopsying the sextant regions and any other ultrasound localized discrete lesions or areas that need to be biopsied are all part of 55707. 55708 is the same, but includes additional biopsies by MRI fusion guidance, and this will include the first targeted lesion. If further targeted lesions need to be performed, the add-on code 55715 would be used for, let's say, lesion number 2 or number 3. That was an MRI ultrasound fusion localized lesion. 55709 and 55710 are the same codes, but using a transperineal route, again, without and then with MRI fusion guidance, again, using the first targeted lesion. The 711 and 712 codes are transrectal and transperineal, respectively, MRI fusion guided biopsies of the first targeted lesion, if only the lesions are being targeted, but not sextant biopsies. There are no sextant biopsies or regional biopsies being performed. The 713 and 714 codes are our in-bore CT scanner MRI guided codes. Again, this is on the CT scanner on the MRI machine. The 713 includes sextant or regional biopsies in addition to the first target. 55714 does not include sextant biopsies. And again, the 55715 code is an add-on code for additional MRI ultrasound fusion or in-bore CT or MRI guided targeted lesion biopsies after the first targeted lesions on the codes that would accept this add-on code. So again, our two ultrasound guided codes are 55700 and 55709. And again, this is without MRI fusion. It's just ultrasound only through the transrectal or transperineal approach. So again, this is our general sextant regional biopsies. Through a transrectal route, it's typically around 12 biopsies. Through a transperineal route, it's typically around 20 biopsies because of the additional anterior biopsies which are often taken. And again, any other biopsies that are performed, either based upon wanting to sample other regions or there are certain areas of concern or cognitive biopsy, would all be included in these codes with no add-on codes, no imaging guidance codes, just these codes themselves. Now the 55708 and 55710 codes are again the ultrasound, but including MRI ultrasound fusion biopsies of the first targeted lesion. Additional targeted lesions, let's say the MRI has 2 lesions or 3 lesions, The add-on code would be used for the second and or third lesion. We have to remember that each lesion is counted once. No matter how many cores are taken from that lesion, sometimes people will do 2, 3, or 4 biopsies of a target. No matter how many biopsies of that lesion is considered one lesion. The 711 and 712 codes are if MRI ultrasound fusion is being performed without the regional or sextant biopsies by the transrectal or transperineal approach. And again, this includes the first lesion, and additional lesions would be reported with 55715 as an add-on code. The 713 and 714 are in-bore codes, whether by CT scan or MRI. And again, the 713 includes both regional sextant biopsies and targeted lesions, the first lesion. The 714 would be targeted without sextant biopsies. And again, the add-on code 55715 would be for additional lesions that have been previously identified on an MRI, which then need to be biopsied after the first lesion. And again, we report per lesion no matter how many cores are taken from that lesion. So then here is sort of our summary slide based upon the procedure, which CPT code to use. If someone does a standard transrectal ultrasound guided biopsy, standard 12 cores, 55707 would be reported. If they do that standard sextant biopsies and maybe added a transitional zone biopsy or seminal vesicle or a hypoechoic area or even cognitive fusion, 55707 would be reported. Transrectal ultrasound plus an MRI fusion biopsy of one lesion, even if there's multiple cores taken from that lesion, would be 55708. That same procedure, if there was a second lesion, then we use the add-on code, so 55708 plus 55715. If there are two additional lesions, for a total of 3 lesions, we report 55715 twice. Transperineal ultrasound, let's say the sextant or 20 cores, would be 55709. If additional cores are taken, again, we'll use 55709 or cognitive fusion 55709. Transperineal plus MRI fusion on the independent workstation. First lesion will be 55710. If there are 2 lesions, again, 55715. Again, if there's a third lesion, add another 55715. The transrectal ultrasound fusion without sextant biopsies, 55711. If a second target, we'd add 55715. And again, if there are 2 targets, but going transperineally, 55712 plus 55715. Our saturation biopsy, which has a very unique and challenging number of biopsies to take. So if this is truly performed, again, one would use 55706. Let's say somebody did a finger-guided biopsy. If there's no imaging available, 55705. And our in-bore biopsies, which are often done by our radiology colleagues, as listed below. So now I want to move on to laparoscopic radical prostatectomy. And again, this is whether it includes robotic assistance or not. And this is for radical prostatectomy, not simple prostatectomy. Again, simple prostatectomy, laparoscopic and or robotic would be 55867. But this 55866 code did not include lymph nodes, and 38571 would be reported if a lymph node dissection was being performed at the same time. The new codes include lymph node dissection. 55868 would be a laparoscopic radical prostatectomy, including robotic assistance if performed, with a limited lymph node dissection. And 55869 would be if a bilateral complete pelvic lymphadenectomy was performed, such as the iliac, hypogastric, and obturator nodes. So we will no longer report 38571 with any of these codes, such as 55866, because that would be considered unbundling, because now there are codes that would describe whether there's a limited or complete bilateral pelvic lymphadenectomy was being performed at the same time. So those would be the correct codes to use. Moving on, there's a new procedure for irreversible electroporation of the prostate, which had previously been reported using category 3 code 0600T. And this is a procedure where Needles are placed into an area of prostate cancer within the prostate and using a very unique technology called irreversible electroporation. That would be what would be used to treat this cancer. And again, 55877 will be the code to use. Again, this includes all procedures that are associated with doing this work, including imaging guidance and the such. Our next code is a unique balloon that is used for BPH. The code is 52443. And so this is a long descriptor. So it reads cystourethropy. So if you do a cystoscopy, it's included, with an initial transurethral anterior prostate commissurotomy. And so that is a balloon which actually then breaks the capsule anterior of the prostate, help open up the prostate channel. And so that is performed initially with a non-drug coated balloon. That's just to break the capsule. Following this, a therapeutic drug delivery with an anti-proliferative agent, because the balloon is coated with paclitaxel, which is an anti-proliferative agent. That drug-coated balloon is then used and inflated in the prostate, and that will help keep the prostate channel open. It's a very unique new procedure for BPH. And again, as any other procedures, anything that is typically done at the same time as the procedure, like an ultrasound, fluoroscopy, cystoscopy, those are all included in this procedure when it's performed. So the really important part about this is that there are two different drug-coated balloons that are currently being used in urology. They are two different procedures, and they should not be confused. CPT code 52284 is for our urethral stricture dilations. And again, with the dilation, then with drug delivery to help keep a urethral stricture open, which is indicated in men with urethral strictures. And it's a single balloon that's drug coated. And again, our new code is 52443, which is our cystourethropy with the anterior commissurotomy, with the non-drug coated balloon followed by the drug coated balloon to help keep the prostate open. So please do not confuse the balloons. Now we have water jet resection of the prostate for BPH. And so this is for men with enlarged prostates. And this is a transurethral robotic assisted water jet resection of the prostate. And again, everything that accompanies this procedure, intraoperative planning, using ultrasound guidance, doing cystoscopy to help control postoperative bleeding, and any other thing which may be done meatotomy and the such, is all included in CPT code 52597. Again, this was previously reported with a category 3 code 0421T. Commercially, this is called an aquablation procedure. You can see there's a robotic arm that goes in there and using a high pressure water jet. This helps clear out the channel to treat men with BPH. Again, our category 3 codes, I mentioned some of this before, but we'll get into each one of these specifically now. There's a new code if HIFU, high intensity focused ultrasound, is used to treat BPH, that's benign prostate tissue. And so the category 3, this is an emerging technology, and so being tracked if this is being performed. The important part is when trying to choose a code, making sure that we're not confusing this for a very similar procedure, which using high intensity focused ultrasound to treat malignant prostate tissue, which should be reported using CPT code 55880. There's a new addition into the open tibial nerve neurostimulator for bladder dysfunction code set. If we remember, there are a number of category 3 codes that currently exist. 0816T, which is open insertion or replacement of an integrated neurostimulator system for bladder dysfunction, and that's placed in the subcutaneous area. 0817T, which is a similar procedure, but when the device is placed below the fascia. And this new code is used for a device that has both a subcutaneous and subfascial extension. Subfascial extension goes under the fascia, and the subcutaneous part stays in a subcutaneous space. We also have to remember there's a CPT code 0587T, which is a percutaneous implantation of a device. Where the top three codes are open placement, the 0587 if it's a percutaneous placed device. And just like everything else, they also have a revision removal code. So our 0818T is revision or removal of a subcutaneous device. 0819 is subfascial. Again, those are the open placements and removals. This new code 0989T is if the device, which has both a subcutaneous and subfascial component, needs to be revised or removed. And the 0588T is if it's percutaneously. The percutaneous device needs to be removed. And so our currently available stimulators, again, there's on the market right now, there's two open subcutaneous devices. There's an open subfascial device. And again, this new device, which is an open subcutaneous with subfascial extension device, and those would be the codes to use for each one of the devices. Next is low energy ureteral lithotripsy. So this is a new emerging technology, a procedure where cystoscopy is performed with injection of the ureter with acoustically actuated microspheres, which then goes towards a stone that's in the ureter, which is then localized, and using low energy lithotripsy, those microspheres are activated, which will break stone that's in the ureter. The important part about this, again, it's emerging technology, and it's important that this should not be reported with 50590, which are shockwave lithotripsy, as we know it, or cystoscopy with ureter catheterizations. And if done on the same side, do not report with cystoscopy with a removal of a ureter calculus, cystoscopy with lithotripsy of a ureter calculus, or cystoscopy with a manipulation of a ureter calculus, and the codes are listed there, which should not be reported. Finally, we have a urethral autologous cell therapy, and this is a procedure for stress urinary incontinence where previously removed muscle cells are sent away, which are then grown in a lab, and then has a very unique device to inject them into the urethra to help treat stress urinary incontinence. Thank you.